I'm going to present in English, but I'm bilingual, so feel free to ask me questions in Spanish in the chat throughout the presentation. And that's Viviana telling me to slow down from the beginning. I am Dominican American, so I tend to speak fast. I'm Gabby Plasencia. I'm a family medicine physician and health equity researcher. I currently practice at El Futuro, a community mental health clinic. And I am a health equity policy researcher at RAND Corporation, which is a nonprofit research organization. And this project is called FIEL-NC, Fostering Insurance Enrollment Among Latinos in North Carolina. And this is a collaboration across many groups, as you can see below. Today, I'm going to tell you about our project, why we started this project, some of the recommendations and outcomes of this project, and where this project is going to go in the future. For some background, many of you might be aware of this. The Latinos make up 11% of North Carolinians, which to date, or based on the most recent census, is over 1 million Latinos in North Carolina. However, even though Latinos are only 11% of the North Carolina population, Latinos represent 28%, or almost a third of North Carolinians without insurance, one of the highest in insurance rates in the country. On insurance, if you look across the age groups of 19 to 64, within the Hispanic Latino individuals, 44% of those within 19 to 64 age groups are uninsured, and that is really high compared to Black and white non-Hispanic groups. So the Black non-Hispanic group, individuals 19 to 64, make up 16%, or 16% of those individuals are uninsured compared to 11% of white individuals, and all that by contrast to 44% within the Latino community. So the goal of this project from the very beginning has been to increase enrollment of those eligible but not insured within North Carolina, specifically through Medicaid and the Affordable Care Act. The project has 3 pillars: the research and policy pillar, the navigation and communication pillar, and the education and training pillar, with the goal of combining research, community education, and communication and navigation throughout the state of North Carolina to improve education and outreach around insurance specifically. We started this project by talking to community health workers. We know that community health workers are the glue that holds everything together, and talking to community health workers to get a sense of how communities, Latino communities, understand insurance, what they don't understand about insurance, what fears they have about insurance, and what might contribute to people being eligible but not enrolled in insurance. We also talked to policymakers and decision makers to understand what strategies have been used to conduct outreach to help people understand what they're eligible for and to get Latinos enrolled. We looked across the state of North Carolina and we identified which counties we were going to prioritize for this project using census data, looking specifically at the proportion of each county that is Latino Hispanic, that is below the federal poverty line, and that is uninsured, right? So this is an estimate of, or a best guess really, of what counties might have the highest likelihood of having a high proportion of individuals that are eligible but unenrolled, because currently there are no good data sources to look at who is eligible but not enrolled in insurance. We know a lot about those who are enrolled, but not about those eligible but not enrolled. I should also say we combined that data with also the knowledge of which community health workers, which organizations across the state of North Carolina also have community health workers, and which counties have LCCU branches, right? It was important to us to identify which counties might have a high proportion of the population that we were looking for, but also which counties have organizations that we can partner with community health workers that already know the area and know the communities. And we were also working with the Latino Community Credit Union because they do a lot of community education around financial literacy, how to do, checking, savings, that sort of stuff. And so we partnered with them to also provide health literacy classes. Out of all this, we created a community health worker training program where we focused on providing education to community health workers about health insurance, about eligibility for health insurance, about myths and facts about health insurance, and we based all this based on stories of real people, right? We know that our community cares a lot about stories, cares a lot about each other, and remembers information better if it's based on true stories. And so we created training programs based on that. And then the community health workers were paid to attend the trainings, to go out and do the outreach and education, and to track, how many individuals they spoke with, and what counties, what areas they were in. So these were the counties, the stars were the counties we identified as our priority counties based on the data that I discussed before. But this is where the community health workers actually did the outreach. And as you can see, they, of course, went to most of our priority counties, but then they were also doing some of this engagement and outreach in counties beyond that. And so this kind of shows the reach of the work that we did. And it also shows some of the community-based organizations that we partnered with, right? We know, especially in North Carolina, there are a lot of Latino community-based organizations, and doing this work alone makes no sense when there's so many organizations across the state that know their communities better than we do, right? We're based in Durham, North Carolina, so let's connect with as many other organizations and community health workers as we can. So these are pictures from a lot of those events that our community health workers attended, and where they conducted a lot of that outreach. These are numbers from 2023, 2024. So we have newer numbers for this year. But in the 2023, 2024 period, our community health workers engaged with 8,190 community members across the state. As I mentioned, we also partnered with the Latino Community Credit Union, and the goal of that was to pair their financial literacy classes with health insurance classes that were aimed directly at community members. And so we called these our Health Insurance 101 module, and they were conducted in person and virtually. These are some of the flyers or, some of the materials from the Health Insurance 101 class. And you can see here, like I mentioned, it's based on, stories. So Maria Luz is a pregnant woman and talking about what she's eligible for through Medicaid and some myths versus facts about that. Jose Fabio, right, is, turning 65, what he's eligible for through Medicare, and so forth. And you can see in the last one, trying to give people specific information about, what is a copay, what is a subsidy, what is a deductible, and all those things, because we know this information is hard to understand in English, so it's even more difficult to understand in Spanish. And then we did train the trainer classes. So we trained community health workers to then train other community health workers on how to lead these sessions for the community. These are some pictures from those in-person classes. And here's some numbers about the outreach and education. Comparing 2023, 2024 to the most recent year, 2024, 2025. As you can see here, and this is in Spanish, I apologize, but I didn't translate it to English. But you can see at the bottom in the first one, and let me see, can you see my mouse? Yeah, so in this first bar graph, you can see the orange is this most recent year. At the bottom, it says, determining eligibility for insurance based on immigration status. And so in this year, you can see that there was a greater interest from community members to talk to community health workers about eligibility based on immigration status compared to last year. Interest about, information to connect to the social service department was about the same. Interest in connecting to resources to get enrolled in ACA was a little bit higher last year compared to this year. Information about the NC Navigator Consortium and people looking for that information was a little bit higher last year compared to this year. And information about Medicare was a little bit higher this year compared to last year. But the most kind of outstanding difference was this first one. Obviously with everything going on, there's a lot more people asking questions about eligibility based on immigration status. These are some observations that the community health workers brought back to us from their engagement with community members. So you can see here, there's a lot more questions about immigration status policy changes in here. There's, of course, there always has been, and there continues to be misinformation and confusion about everything going on. Language, technology, and system navigation challenges continue to be an issue. And you can see here some of the quotes from some of the community health workers directly. Of course, the community members often will tell the community health workers, how helpful they have been, and how they are a trusted source of information and support, connecting them to things not just insurance, but also, the community health workers work in these areas and know about a lot of the resources in these areas, and often are able to connect individuals and families to resources outside of just, health insurance enrollment. We also did a survey and focus groups to get an understanding of what were the Latino community members' experiences with Medicaid expansion, right? Medicaid expansion led to a big push in information, in community engagement, to get as many people enrolled as possible. And North Carolina actually did a, pretty great job in getting people enrolled. And North Carolina was one of the states that had the highest amount of Latinos enrolled in Medicaid after Medicaid expansion compared to other states that went through expansion. Now there is some evidence to show that a lot of those Latinos that were enrolled after Medicaid expansion actually were eligible prior to Medicaid expansion, but that Medicaid expansion, because of the push for community engagement and for sharing more information and conducting more outreach, actually was able to connect to a lot of Latinos that previously weren't aware of the fact that they were eligible or hadn't tried to enroll before. So based on that, we wanted to get an understanding of, how did Latinos feel about Medicaid expansion? Did they attempt to enroll? Did they consider enrolling? Did they try but find it too difficult? What were some of the barriers? And as you can see here, 25% considered enrolling but did not enroll in Medicaid after expansion. 17% of those who answered the survey attempted to but did not enroll in Medicaid after expansion, and 25% enrolled in Medicaid after expansion. And this 33% were those who did not consider at all. And we tried to ask the question in the survey, why not? If you did not consider enrolling, why not? And a big reason why we asked that is, we want to know, is it fear? Is it they didn't think they were eligible? We've heard, community health workers tell us that in the community, there's this misconception that Latinos aren't eligible for insurance, right? Like that's a very broad statement. And so we want to try to understand what were some of those barriers. And so 33% did not consider at all. We don't know the eligibility, obviously, but if you didn't consider at all, then it's hard to know whether you would have been eligible or not. And here, this is kind of the proof of why we continue to work with our community health workers. You can see here the difference in health literacy or self-reported knowledge of health insurance topics across community members and community health workers. So the blue, let me make sure I say it correctly. The blue, I want to say, is the community members, and the green is the community health workers, right? And when asked, how confident do you feel or how much knowledge do you have about health insurance topics, community members would say, 4% said they had no knowledge, 39% of community members said they had minimal knowledge compared to 9% of community health workers. 39% of community members said they had average knowledge, whereas 27% of community health workers said they had average knowledge. And 56% of community health workers said they had adequate knowledge compared to 11% of community members, and about the same 8% versus 7% of community members, community health workers said they had superior knowledge. And the reason this is important is because we're doing the training where, providing funding for community health workers to go out and engage with communities about this. So we want to make sure that they feel confident that they have the knowledge they need to go out and do this. And that they are able to help the community, improve their knowledge on health insurance topics as well. We created a training toolkit so that other community organizations that work with community health workers could take the materials that we created, could take our trainings, could take our modules, and go ahead and disseminate it within their own communities. We translated it into English and Spanish because we know that just because populations speak English doesn't mean that they're connected to resources or know, their eligibility and know about health insurance topics. And so the goal of this is to share this through KBR so that more trainings like this for CHWs exist, not just in North Carolina, but outside of North Carolina to help Latinos and other marginalized populations get enrolled as much as possible. These were some of the locations where we did in-person classes with LCCU. This is the flyer for those classes with LCCU, so you can get an idea of some of our advertising and some of the work that we've been doing. And this is a summary of all of the research publications that have come from this work. The reason I put this is not to show, the research as the most important part of this. It's to show that we are trying to not just engage with community and learn from community and gather community voices and stories, but also put that in a format that then we can share with policymakers, decision makers, institutions, right? When I go, for example, to the Medicaid Medical Advisory Council or the Governor's Minority Health Advisory Council meetings, I can tell stories about my own patients. I can tell stories about what I'm seeing, in communities, what I'm hearing from community health workers. And for the most part, people say, yeah, that's great. That's just one story, right? But if we collect this information and put this into peer-reviewed journal articles and conduct rigorous research, both qualitative and quantitative, to show not just what we're hearing from individuals, but then show this at a collective level within counties, within the state, then we can hand this over to policymakers and decision makers to show, hey, this is why this is important. Here's the data to show that this is important. And here's what we recommend based on the evidence, right? Now we have evidence-based recommendations. And so one of our tools as part of this project has been to translate what we're learning from community, what we're learning through this project into research, right? Using rigorous research methods so that when we tell policymakers and decision makers what we think is going to be more helpful for the community, we have the evidence to back it up. And if anybody wants links or wants to talk about any of these publications, I'm happy to share. So out of all of this work, we have seen over and over again, the same recommendations come up through, conversations with community health workers, with community-based organizations, with community members directly. Number one, increase funding and support for community-based events in trusted locations with Spanish-speaking providers, co-led by trusted community-based organizations, right? We've seen this over and over again. We saw this during the pandemic, and we're seeing it now. People don't know where to go, right? But if we do community events out in the community with trusted people, organized by trusted organizations, our community members are going to feel more comfortable going out there to receive information, to ask questions, and trust the information that they're getting. Number two, community outreach and engagement through community health workers can decrease fear, increase trust, and improve healthcare system navigation for individuals not previously engaged in the healthcare system, but also those currently engaged in the healthcare system. I can tell you as a physician, when I help my own parents get enrolled in insurance, when I help them make their medical appointments, when I help them pay their medical bills, all of that is very confusing to me as a physician, someone who knows the system. So imagine if you don't speak the language, you don't understand the system, you don't even understand the insurance coverage you have, having community health workers to help through that process is extremely beneficial, right? And so one of the recommendations we give over and over again in all of the research that we put together and in our discussions with policymakers is that this community outreach and engagement needs to be happening. It needs to be happening through community health workers, people that come from the community, that look like the community, that have the same lived experiences or similar lived experiences as the community. Create sustainable funding mechanisms to support community-based organizations, community health worker programs, and community coalitions to maintain and strengthen existing partnerships leveraged for future public health and socioeconomic needs. We've been saying this since before the pandemic, and the pandemic only showed how important this is, right? Community-based organizations are doing the best they can. They know the community the best, but community-based organizations often are funded by grants that last a year or two, then they run out. And then what happens to those programs and all the effort that went into those programs and all of the people that became dependent on those programs? They disappear, right? Community health workers are a big example of this, unfortunately, right? Often community health workers are paid through grants that they got from the community-based organization, that the community-based organizations got, right? And so the community health workers might be paid, a few hours a week here, a few hours a week there for a year or two. And often community health workers, especially nowadays, are working, and I might be preaching to the choir because I know we have a lot of community health workers on our meetings usually. But often community health workers are working, multiple jobs to piece together a full-time job, because they're only getting a certain number of hours, from each program, from each organization. And each of those jobs is for 6 months, a year, 2 years, etc. So we need to make the things that our communities rely on more sustainable. And we need to find a way to work together in a more sustainable way. So community coalitions, right? Groups that bring together community-based organizations, share information across community-based organizations, are important to sustain, because we saw during the pandemic the impact that had, when we were working in silos, and the difference it made when we started to work together across community-based organizations. And then the pandemic ended, or decreased to some extent, and we were all talking about the future pandemics, right? But what is happening right now in the political landscape is as threatening to lives, to human lives, as the pandemic was, if not more, right? So now we have another crisis on our hands, and the funding that supported a lot of CBOs, CHWs, and community coalitions has decreased significantly. So we will continue to advocate for sustainable funding for this. And this last point is based on the gap that we have seen in the way community health workers, community organizations, policymakers, and academics talk about similar things. So increase alignment in language utilized by healthcare providers, researchers, community members to improve data reporting, collection, community engagement, and understanding of genetic and social cultural factors impacting the health of diverse Latino communities. Often what happens is that community members, community-based organizations, community health workers are saying the same thing, or have been saying the same thing that the academics, the policymakers are saying, but they're saying it in a different way. And so one of the things that I think about is, how do we train community health workers, community organizations, to think about research and policy in a way that decision makers and policymakers understand? But also, how do we train policymakers and decision makers to listen and to understand what community members and community-based organizations, community health workers are talking about? So there's a gap in the way we talk about things, even though we're talking about the same things often. The issue becomes that there have been a lot of policy changes. This is a packed slide, but I wanted to make sure I put my sources and I provided a little bit of guidance as to what I'm talking about. And here I'm talking about specifically the impact of these policies on this research, when we know that the impact of these policies are far-reaching, and we are only starting to begin to think about what impact these policies are going to have. Number one, there has been an agreement between DHHS and ICE, meaning that all of the information collected or a large amount of the information collected to help people enroll in Medicaid, Medicare, SNAP, WIC, anything through DHHS or CMS, that information is now eligible to be shared with ICE, right, with immigration enforcement officers, including addresses. So what does that do? that increases the fear of enrolling or re-enrolling in public benefits such as health insurance, NAFWIC, and other things. The One Big Beautiful Bill Act, OBA, as it's now called, did a lot of things. But specifically around health insurance, it reduced public benefits eligibility. So groups like asylum seekers, refugees, et cetera, are no longer eligible for some public benefits. It reduced Medicaid funding for states. It has put in language that increases the frequency of redetermination. So that process of re-enrolling, providing information to make sure that you're still eligible for Medicaid and public benefits is going to happen more often. And work requirements or community engagement requirements are put into place for certain populations, which we know from states like Georgia that have had this for a while, does not increase productivity or the workforce, and actually just prevents people from enrolling in and using public benefits. And there are large budget cuts to resources like the Navigator Consortium, which has been instrumental in helping people actually sit down and enroll in health insurance. We help people understand whether or not they're eligible, and then we connect them to groups like the Navigator Consortium. But now there's been massive cuts to that. So what does this do? This leads to fewer resources to provide the services, reduces eligibility, and increases barriers to enrollment. Finally, there were changes to PRORA, which is the Personal Responsibility Workforce Opportunity Reconciliation Act. I think I got that right. And this bill, now, what the change that they've made is that they have now restricted access to public benefits to those who are quote unquote qualified immigrants or those with qualified immigration status, which again restricts the populations that previously would have been eligible for a lot of things. And so this, of course, will restrict access to undocumented individuals, but also restricts access to those like asylum seekers, refugees, et cetera. And they expanded the list of programs that are considered public benefits. So public benefits traditionally have been seen as things like Medicaid, Medicare, SNAP, WIC, but now they've put things like Head Start programs, education programs, and other programs, not just health insurance specific programs and nutrition programs in the list of public benefits, further restricting access for these populations. One of the biggest issues with this is that this increases fear of using FQHCs, federally qualified health centers, which have been traditionally one of the main sources of health, safety net, health resources for immigrant populations, including undocumented populations. So our work has focused on increasing enrollment or increasing awareness of eligibility and outreach and education around health insurance for a lot of populations. But can we truly continue to help people enroll if there are a lot more risks involved with enrollment in health insurance, right? So these are some of the things that we are thinking about now. How do we change our project, and how do we change our goals to better fit the needs of the population right now, or how those needs are going to change? Because we're only beginning to understand how that might change. So where do we go from here? Some ideas that we've been talking about, and we are very open to conversation about this. Focus on accurate and timely information sharing. One of the things that we've been doing between the three of us and others that have been involved in our group is meeting with NCDHHS, meeting with other community-based organizations, meeting with community health workers to discuss what is happening right now, what does the community know, not know about this, how do we think this might be interpreted. Just because it's been passed doesn't mean that everyone is going to interpret the policies exactly the same. And just because it's been passed doesn't necessarily mean that it's going to be implemented right away. So when is it going to be implemented, and how is it going to be implemented differently across different states, different organizations, et cetera? And so we have already requested this sort of information through the channels that we are connected to. So NCDHHS, the Medicaid Medical Advisory Council, Minority Health Advisory Council, et cetera, trying to understand what they're thinking about this and what guidance they have for us to share with community members directly. Number two, assess the evolving needs in the community and identify solutions to meet those needs. As I said, we don't know how it's going to be interpreted or implemented. We can predict some of the impacts it might have, but we don't know for sure. And so we're going to have to continue our boots on the ground approach of working with community health workers that know the community, that are embedded in their community, to hear directly from community members what is happening and how it's impacting them. And number three, continue what we've been doing in this project, which is raising the voices of communities to decision makers to advocate for change, right? We don't want to just listen to community and report it, in research papers. We want to use that information to go directly to decision makers and say, hey, this is what is happening. These are the stories, this is the data, this is what is happening, this is the impact it's having. And these are the recommendations from community members about what changes they need, what solutions they need to address some of the issues right now. This is a picture from a hurricane. I'm from Miami, Florida. And you can see here, whenever there's a hurricane, the biggest, strongest looking trees are always the first to fall down. Their roots get completely pulled out and they're the ones that are knocked over. And then the thin, flimsier looking palm trees are the ones that remain after a hurricane. And I feel like this is an analogy of the work we're doing right now. We are trying to find solutions and identify what strategies are going to be more like the palm trees, resilient, and not necessarily the biggest, boldest, but resilient and flexible, so that when this hurricane passes, our strategies, our recommendations, our networks, coalitions, those remain in place. They might lose some palm fronds, but those remain in place. And so that is how I think about the work we're doing right now. How do we create these palm trees, grow these palm trees, despite the hurricane going on around us? This is a quote from an ecologist. In a hurricane, palm trees are very pliable. They can move with the wind and the fronds often fall off, but they can grow back very quickly once the storm has passed. That makes palm trees very storm resistant. We want to make our strategies, we want to make our recommendations, our work storm resistant, because we've seen enough storms and we've seen the effect it has on our communities. And so we want to hear from you all, and we want to continue to work together with communities, with community-based organizations, with organizations, agencies, institutions, to figure out what are the best ways to make the work that we're doing storm resistant. This is me and Vivian are PIs on this project, and Paulina is our amazing project manager, but there are many, many other people involved in this project, not just us. But we would love to hear from you right now in the meeting, or feel free to email us, talk to us separately if you have any other questions. Thank you.